you now. So let's talk about an important topic today: pain relief is human right. I'll take you through this. This is a pictorial presentation, but yes, there's a lot of message around. Pain is as old as mankind. Yes, it's still mysterious, and we are trying to fight it out for ages together. Now we have tools in hand, and we can really do justice for these patients. It has become a burning problem of today's times because the digital world and these young kids, young boys and girls, they're falling prey to this problem because our evolution has been in thousands of generations. And what is happening in the last 1 or 2 generations is a tech revolution, and our evolution is not able to catch up with the tech revolution. That's why young people are getting into this trap. But it's more important to teach them, educate them, tell them where they really can avoid it and really have to correct their postures. And this is one of the important things. It has become a lifestyle disease. Under-treatment pain is a pandemic. It's a global phenomena. But we, with good pain management, can really do justice for all these patients and can really put them back on track. They said it's cruel to deny people in pain to access to effective pain interventions. That's where Yashoda is doing its bit now. So chronic pain is a multidimensional issue. It's not just the physical pain which is there. It's a lot of functional, emotional, spiritual, and social aspect. And over and above in Indian setting is the financial aspect also, which is important. And especially with the bed earners get into this trap, the whole family gets into a problem. Patient needs help. We keep seeing these patients day in, day out in our clinics. Look at this patient. I call it it's a wrong on part of the medical fraternity. If you allow patients to burn their back for want of the help, want of pain relief, it's not great. So I think probably that's where we fail, and we have to succeed thereon now. So the people have been doing, they get onto the painkillers themselves, they go to the chemist shop, and then they have analgesic nephropathies. In Indian subsetting, we have the diabetic capital of the world. If patients taking painkiller along with the diabetes, we are adding fuel to the fire. And then you really realize, and patients many times, they're getting intelligent now. If you tell them painkiller, they say, no, good. So, and another thing is GI bleed. We have gastro people around, they know how important it is to really educate people. They don't take too much of it because the acidity and everything comes up. And another bigger problem, which is the opioid pandemic, which is in the Western world, which is the painkiller which they tend to start. Now they are going away from it, and it's a less and less opioid is being used. But sometimes people go for surgeries, good, but sometimes hard luck chases. This gentleman has gone for 3 surgeries at different times and still in pain. Look at this list, still in pain. So that what next? He's taken his last step and thereafter still in pain. So we have a provision, interventional pain management, doing good justice for these patients who are either going for advice for a surgery, we can really pull them out, or they are suffering because of the pain and you can really make them pain free. So that's the role of our pain specialists around. And especially younger people in this modern time, we have so many young people coming with the joint pain, MSK pain, and chronic pain scenarios. It is demography changing. What is used to be 30, 40 years back is changing now very, very fast, very rapidly. Our kids and grandkids are falling prey to this. So let's pull them out and give them a pain-free life. Radiofrequency ablation, this is one good step to make them pain-free. Another is very vital, which you're going to hear today, very good topic on this, is regenerative combo therapies. We are trying to combo the pain relief along with the regeneration and repair. And we have so many molecules now available, PRP, GFC, BMAC, ACP, and exosomes and micromolecules are coming up. It's a very, very rampant new science coming and very, very helpful for the patients. So people are really doing good work with these molecules now, especially younger people. I'm happy. I told you, like many people go for knee pain. You can do a knee pain relief with the radiofrequency and regeneration with your all regenerative therapies. It is taken over the steroids. Steroids are bad in long run. And without any side effects of steroid, you can give them pain relief. And this is the platelet rich plasma. It works from head to toe. It's not just one thing. In many athletics, many sports people are making use of this now. Celebrities also, so it is becoming into a fashion now. But yes, it is a relief. And initially people didn't believe, but you can repair things. That's something what you really want. You have your own body with you. And like in a frozen shoulder, people are having a pain. Physio, anyway, you have to do all this conservative management for 4 weeks first. But if it doesn't give you a result, there is a solution for that. And these are the frozen shoulder people. We can do the regenerative medicine, and you have a tennis elbow, and again you can do regenerative medicine. It's just a jab, just a needle, and we use 26 gauge needle, so it doesn't really bother pain, and relief is near permanent, by the way, and it can be repeated if need be. but it's a permanent solution. So here you are making your body anabolics, there's no catabolic inside the body. Lower back pain has always been a puzzle, especially lately. More and more people are with younger people coming into this, and you don't know. There are so many pain generators in the lower back, be it the facet, be it the lysis, be it the disc, be it the androgenic, and now we need to talk about the vertebrogenic pain. It is a new thing which has come, modic changes. It can cause pain. It was not there a few years back. There is a very good treatment, BBN ablation is there, which help these people. But it's important to diagnose what is the target, where is the exactly pain generator and targeted, and effective interventions are there. Spine injections are taken over all these big surgeries now, and who wants a knife if you can manage needles, obviously, and that's the desired treatment for many such patients. Regenerative therapy for this disease, I told you younger people falling prey to this. If my son gets into this problem, I like to advise for regenerative therapy, then I'm going for any higher treatment modality, and that is it. And we are comboing it with the surgeries. If you're doing a spine surgery also, still we're comboing with the regenerative medicine. And even many orthopedic people who friends around, they know the regenerative medicine is giving a better result when they combo with the surgeries, even if it is open surgeries or endoscopic surgery for that matter. It's era of MAS, minimum invasive interventions is there. Endoscopy is doing a good justice for these patients. Like one patient who came with a foot drop, and there's a large disc piece in there, and patient had a foot drop. In one go, you just put in a scope 6.5 mm, take the disc out, and patient is walking back very next hour and walking back home and back to work by next week. Otherwise, if you leave them alone, these foot drop can be permanent for these people. These paralysis and all these injuries can be permanent. So you have to act proactively in emergency scenario if that is the case. He is talking about a friend of his. He is the friend we were talking about. With the first patient, we did the ultrasound, intradiscal ultrasound in the world, by the way. And we can name it after him, the procedure. So that's the ultrasound work. And once we did the procedure in the post-op room, and the very next hour he's walking to the loo, and look at this, is talking to his family and friends on the phone. That's a litmus test for these people. If you can give them pain relief, and they're back to their phones, they're glued to phone, that's wonderful for these people. Yes, we talk about failed back surgery, but also post-surgical syndrome. This gentleman had 6 open surgeries and 6 interventions, still suffering in pain. Going places from world over places, from Thailand to Egypt and whatnot places, and is not getting as a good pain relief. He came to me, and obviously the next best option is the spinal cord stimulations. We do have the spinal cord stimulation, DRG, PNS, and reactivated, which is doing justice. It's like pacing the spine, like we have a pacemaker in the heart, same way we pace the spine. And it really takes the pain away. It blocks the pain pathways, and that's what it is, like a gate control theory, where we got the Nobel Prize. People who are having a headache, we have some provision for cluster headache. We do a supraparietal ganglion block. But yes, it's quite often it's the trigeminal ganglion which is causing the problem, and it's a simple treatment. People are taking medicine for tens of years or decades and decades, and with one good intervention, they get the final relief, and which is for years together. Again, a repeatable procedure if need be, but mostly it is one time is more than enough. But it's realized they come from dental clinic after half the dentures are gone. That's not coming from the dental area, it is coming from the trigeminal area. So put in a needle here, block the trigeminal nerve, pain is taken care. But then there are some subset of patients who are orofacial cancer. India is the capital of the world orofacial cancer because of the tobacco chewing and other things, tobacco chewing, and they get these kind of things. They're dying, they know it, the death is imminent, they're seeing the death. But who wants to die every day? That's the whole problem. That's where you can really block this cycle of dying every day. You give them pain relief, and they are back to family. That's important. I think it's the most human job you can do. And pain relief is more terrible than the death itself, and just sympathy is not enough. I've seen patients, relatives, even doctors standing by the side of the patient and just sympathizing or just looking at the patient, or put them a heavy dose of narcotics or sedatives, which is not good, and they cut off before they really die. And pain, pain warriors, they can fight against pain and put them to their families back. Celiac plex is one of the problem. Treatment is there, because if there is anything gastrointestinal cancer, which is right from the gastroesophageal junction up to the splenic flexure of the large colon, be it liver, gallbladder, or pancreas, and you can give a permanent relief for the years to come for these patients. And I've done for this, even for the chronic pancreatitis patient, and you put in needle CT guided. We used to do fluoro earlier, and now ultrasound is very big helpful for tool in these patients. And you can do in a cancer setting by the bedside for these patients. And you put in a needle, put in a drug, the pain pathway is closed, done job. And patient wants to go back home. And another thing is like in a pelvic malignancies or for the metroperitoneal malignancies, chronic pelvic pain, bladder pain syndrome or dysmenorrhea, these patients, when they have the problem, you can do a superior hypoglossal plexus block. You do it fluoro guided, wonderful, done for ages, but radiation issues is there. Now we're doing an ultrasound guided block. A good ultrasound machine really makes the life very easy and simple. I told you, chronic pelvic pain is a problem of sometimes young ladies, corporate ladies in active careers, very educated ones, and they have a pain in the pelvis, and they always, think, they say it's a headache in the pelvis. And the problem gets bigger. When the doctors, they don't believe, they say it's in your head. If they don't believe it's in the pelvis, that my Euro friends are there, they would understand it's a very, very big problem. So there's a double pain now. Patient has got a physical pain and you're given a mental pain because you didn't believe the patient. And thereafter, and by the way, patient is looking for help, and patient feel helpless, all the more reason to, they suffer further on. The pain is real and treatable. Please, there is no merit in suffering. And with so many treatment modalities available, hypoglossal plexus block, impar block, platelet nerve block, and spinal cord stimulators, you cannot lose the battle if you have so many immunization with you. So you give them pain-free days, leftover days, or pain-free life thereafter. So you decouple pain, that's the whole point. You break the cycles, decouple pain, and mission is accomplished. You give them an easy life. Like a patient, young boy, I say God even cruel. I saw in a long time back in a cancer hospital, 5-year-old boy with the neuroblastoma. You see God has given birth to take him back very soon. But then you have the catheter in place. It was a very big pain, howling. Who wants to see baby crying in pain? So put in a catheter, you put those Baxter's flexometric pumps, and you put the drugs in here. And for 4 months together, we could give him a nice, good pain relief to this child. Well, when you can't add days to life, the point is you start adding life to days. That's what it is for these terminal cancer patients. Please do justice for these patients, and you start gifting them smiles. This lady had a CA breast, and later on she developed secondaries in the liver, and this is just a month before she actually died. She's back with the family. So you're really gifting something back to these people. Another gentleman who came very recently, 6-level fractures, multiple myeloma, and then he was stooping, he was not even walking, and then almost cut off again from the life. And you put them 6 level, I did 4 kyphoplasty, 2 verteplasty. It's a very high-end procedure, but very much doable if you do a good job. And patient got look at the patient face, by the way, my friends. Look at the patient face, such a smile as soon as he off the table, OT table, right on the trolley, such a big smile. Well, I'm so happy, it's $1 million smile, I call it. So there's a novel plasma therapies are coming now, very, very new science. Let's put science into action, and we are burning the tumors away, and then refilling with the cement now, and you go to the post-procedure room and patients walking. What else you want for these patients? Sometimes life is limiting, but you want to give them quality in that limited time. With the age expectancy, we know it, we all are going to grow older and have osteoporosis. Some people have osteoporotic compression fractures coming up, even with tribal traumas. You have a patient fall in the Gurdwara, had a fracture, put the patient on table, put the needle in, cement in, and it's a quick fix for these fracture spines. Very effective, very good treatment, but until unless patient realizes, doctor realizes, you can really put them back to work in a month time or 2 time. I've seen in US and other places, they do drive the car to the place, get the cementing done in 3 hours, go back home. So that's what we have to. I did a 6 level in long back 2010, and that was a record that time. Now people are just doing thereafter more and more of it. I have devised a technique. You can't do all this procedure until you have a new technology, that I put a anti-epidural safety balloon behind the vertebral cortex, and I just put my cement work inside, and that's a safety. When you do all these high-end procedures, safety gets vital. It's like a pilot flying the plane, then you have a jet person flying the jet, so you have to have a safety in mind. I just show you a patient who's got a 6-level cementing, by the way, fracture spine, 6-level screws fixation is being done, but the fracture didn't unite, and patient was in pain. Put in a needle there, put the cement in there, and just do a nerve block there. Look at the incision size, the surgical incision size, and what we did from that small hole, and this is the difference. And this could have been done with the small hole itself. Now there's a vertebral augmentation, and this lady, by the way, just to give you an idea, that this couple, old couple, many of scenario, model demography, modern society, many people are loners now. Kids are gone and they're all alone, and they're going to grow old, and then going to have old age issues. She had a fracture spine. Look at the fracture spine, and the kids can't come back. They have their own life and everything, so the patients are left to suffer. Once they have fracture spine, you can't go to the washroom even. So what life it is. and it happens to the couple itself. It's not the person suffers. If the family suffers, then society suffers. It becomes our duty, pertinent duty, that what best we can do for these people to put them back on track and give them quality of life. And this is what I do with the same epidural balloon. I did a cementing in this lady, and well, the patient is happy, you are happy, and they're back to home, and again back to work, back to kitchen rather, for this lady. So you are, by the way, God sent. I keep telling my friends here who are sitting here, and you're given a responsibility somewhere, that do your best, be your best, and deliver the best, so that you can really take the pain off the society, of these people who really need you most. Unless you do it, do you deliver it, they're suffering around. I think probably I always feel that yes, it is our duty, medical duty and social duty, and over and above, I put it to myself, it's our human duty to give pain relief to such patients, if we can, if we should. And by the way, all these people are their liabilities. Old people, they are assets in the families. And once they get into sick units, they become liability for the family. And you turn those liability back to the assets. That's what you're trying to do, and that's what the whole thing is all about. The vertebral augmentation is a magic wand. With all these orthopedic fractures coming up, and I do it in burst fractures, vertebral planars, I do it in retropulse fractures here, I do in multiple levels, and I do it in the retropulsing fracture in the malignant fractures. I do it with my innovations. It is doable. Please, you can learn it, do it, and you have to be master in your game. Any game you play in life, you be your master and do it, deliver it. Why not? And that's it. And healing touch, keep gifting smiles and happiness all around. Some people, they are asking, what a pain, and they will beg for death. I have had people who are asking for suicide, and there have been instances because of pain. A lady died and she said, I want my daughter to be a pain specialist. That's the scenario, because pain is a pain is a pain. And then if you do a good work, then you have the smiles coming back. This lady had a foot drop. I did a procedure on her, and she was all fine. I'm very happy that her foot drop totally recovered 100%. I'm so happy for her. So let's keep igniting more minds, and we have to make this world pain-free. Through education, through knowledge, through skills, and through wisdom. And we have to do it as a pain relief is a human right. When I say pain relief is a human right, there is a second line. It is our duty to deliver that pain relief. It bounces back on me. Okay, if patient is asking for it, I have to deliver it now. It is my responsibility. So we can have those smiles all around, and we're not doing for ourselves. We are doing for generations to come, and we want to leave this world more pain-free, more efficient, and more effective. So it's a choice which patient has got. Either patient lives pain, or he leaves pain. So we always try to do our bit, one way or the other, which way or the other. I wish you all learn, take some message home, and please do your duty. We all together make the whole fraternity, medical fraternity is all about. So let's do our duty, and thank you friends for your time. Thank you so much.